Hi, everyone. I think we'll go ahead and get started. I'm Dr. Victoria Kirsch, the National Scientific Coordinator of CanPath and Scientific Director of the Ontario Health Study. Welcome and thanks for joining today's CanPath webinar. We'll start things off with a land acknowledgement. We acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples, on which the CanPath National Coordinating Center at the University of Toronto now stands. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. With CanPath teams working across Canada from coast to coast, we acknowledge the ancestral territories that are home to many Indigenous peoples from across Turtle Island, and we're grateful to have the opportunity to work on this land. So today we're going to hear from Dr. Alton Russell, Matthew Knight, and Dr. Yuan Yu. Dr. Alton Russell directs the Data-Driven Decision Modeling Lab, which enables the efficient, effective, and equitable use of finite healthcare resources using data science and decision modeling methods in the McGill School of Population and Global Health. As scientific advisor to the COVID-19 Immunity Task Force until 2024, Dr. Russell led projects to understand and correct for bias in studies of SARS-CoV-2 infection and immunity related to representativeness, sample collection method, and assay performance. Matthew Knight is the data manager of the Canadian Co-Infection Cohort Study at the Research Institute of the McGill University Health Centre, where he works alongside team members to maintain study databases, implement and document data harmonization initiatives, and support investigators with study analyses. He recently completed his master's degree in epidemiology in the Data-Driven Decision Modeling Lab, where he analyzed the sociodemographic representativeness of 6 Canadian serosurveillance studies under the supervision of Dr. Russell. And then finally, we'll hear from Dr. Yuan Yu. She is a statistician who previously joined Dr. Russell's decision modeling lab at McGill for a serosurveillance study collaborating with Canadian Blood Services. With a background in Bayesian statistics and survey sampling, she has a broad interest in Bayesian applied fields, utilizing healthcare data resources. So after their presentations, we'll have time for questions. Please use the Q&A button at the bottom of the Zoom window to drop your questions throughout the talk, and we'll get to them soon.
Great. Well, thank you, Dr. Kirsch, and thank you to the CanPath team, Megan and Tamara, for all of your help setting up this event. So it's my pleasure to be with you virtually, and as well with 2 of my former lab members. So Matthew Knight was a postdoc until the beginning of this year, and Yuan left around the same time after her postdoc. So I'm going to go over some background, and then I'll hand the floor over to Matthew to talk about his analysis of the representativeness of different SARS-CoV-2 serosurveillance studies in Canada. And then I'll let Yuan talk about her analysis, which is focused on statistical adjustment to improve representativeness. And then I'll take back over to talk about future directions. So just some high-level background on serosurveillance. Serosurveillance is typically when we're measuring antibodies in the population with different objectives. Often we're trying to estimate the population level exposure to different infections and or vaccination, because you can get antibodies from a natural infection, from disease, or you can get them from vaccination. This information can help us understand transmission dynamics. It can help us to identify immune gaps. So are there segments of the population who have less protection against infections? And they can inform public health interventions such as vaccinations and social distancing. But in order to achieve these objectives, it requires that the population that we're sampling in, that we're testing for antibodies, resembles the target population, or at least we can make adjustments to the population to get estimates that are representative of the target population. And when we talk about representativeness, there are a whole lot of different dimensions. I just kind of brainstormed a few here, from demographics like age, sex, gender, sexual orientation, health-related dimensions. We know that people with compromised immune systems oftentimes are more susceptible to severe illnesses or are less likely to be protected by vaccination. There's geographic ones, neighborhood, urban, rural. and of course, race and ethnicity, cultural heritage, First Nations, all of these things are different dimensions that one might consider. And so statistical adjustments can help us to improve generalizability of our estimates, as long as, when there's imbalance in your sample, but only when group members, like for a group that you're interested in making sure you can generalize to, is represented. In other words, like if you have a large enough sample, you can adjust for the fact that a certain demographic group is underrepresented, but you can't do much about it if they're just absent entirely. And so the group has to be present in your data set. You also have to measure it. So just, knowing that 10% of your sample is from rural areas doesn't help you adjust for that if you don't know which 10% came from rural areas, just to give an example. And generally, you also need to have a target distribution. So if I think that people from rural areas are underrepresented, but I don't know the proportion of people in my target population that are from rural areas, then that limits my ability to adjust for that underrepresentativeness. And when we're doing serosurveillance, sometimes, like in the case of the SARS-CoV-2 studies we'll talk about today, we're trying to generalize to just the general population or maybe the general adult population. But for certain questions, we might actually be wanting to focus on specific groups. So for example, like, measles is a health condition that is mostly asymptomatic in adults, but can be deadly in children. Mpox in North America, at least, is primarily transmitted through sexual behavior among men who have sex with men, right? And then SARS-CoV-2, as we all know, is a respiratory illness that can kind of affect the general population. So, let's say that you could use residual samples or leftover samples from a sexual health clinic. CDEP is one in Montreal. You could run serosurveillance like we did for SARS-CoV-2 among participants in CanPath, the longitudinal study, or you could potentially do serosurveillance at a pediatric emergency room, but it wouldn't make sense to study measles in a sexual health clinic, and it might not make sense to study Mpox in CanPath, just because the population, the number of people who would potentially have infection would be relatively small. Or to study, and maybe it would make sense to study SARS-CoV-2 among hospitalized patients, depending on your interest. But generally, we want to kind of align the population for serosurveillance with both our pathogen of interest and our research question of interest. So when it comes to representativeness, why might a study population not be as representative as we would like? One reason is selection bias, which is asking who was selected to be included or who was invited to participate. So this selection bias can be along geographic lines. A lot of times it's harder to reach people from more rural areas, as well as different demographic groups or clinical groups. So people with certain health conditions might be underrepresented or absent from our sample because of who we're inviting. And this can be partly mitigated using probabilistic sampling frames. Non-response bias is kind of another layer of bias that impacts representativeness. So this is who accepts our invitation. And if you look at survey researchers and across various disciplines, they've shown that over the last kind of 30 or 40 years, non-response bias has really increased. So, landline random phone calls used to be a recruitment strategy, but it's not done nearly as often anymore because millennials and younger don't have landlines that often, and also often don't answer numbers they don't recognize. So there's different ways to reach populations, but it's generally harder to do a random sample these days, and have people respond. So, in the case of serosurveillance, when we use residual or leftover blood that was routinely collected, so this could be people who have outpatient labs run, and then we can do serosurveillance in these populations, which was done during SARS-CoV-2. We actually eliminate non-response bias because in some cases, you're able to do this ethically without consent. Of course, you're never linking responses to individuals or in that situation, but you can eliminate non-response bias. However, this is in very select convenience samples where the selection bias might be high, potentially higher than other types. And also you might have more limited contextual information, because if you aren't actively consenting participants, you can't administer a survey to them. So you're kind of limited to whatever administrative data you have about this person, maybe their address and their sex, and things like that. Okay, so that is a bit of background. Next, I'm going to turn it over to Matthew, who's going to talk about his study, which is on the representativeness of SARS-CoV-2 serosurveillance. And you can see here that it was published earlier this year in BMC Public Health. So I'll let Matthew take over, and I'll give you control.
Great, thanks, Alton. Okay, we're going to see if I can do this. Can I just click? Oh. There we go. Okay, great. So serological surveillance was an important component of Canada's SARS-CoV-2 surveillance strategy. And between April 2020 and February 2021, a lot of studies began testing blood samples for antibodies against SARS-CoV-2. And this helped provide decision makers with estimates of things like population immunity. And these studies can be broadly classified as either a convenience sample, which is a sampling strategy where participants are selected generally based on the ease of access, a probabilistic survey, which is a strategy where participants are recruited using probability-based methods, and this is often considered a gold standard, or a de novo cohort, which is just a new study, and this allows tailoring recruitment to the research question. But these studies faced a lot of challenges during the pandemic, so social distancing, resource limitations, and also a need for timely data, which led to studies using a variety of recruitment strategies to test participants or get serology samples for testing. And what we really wanted to assess was how this could have influenced their representativeness to the general Canadian population. Gotta find it every time. Here we go. So to do this, we analyzed demographic data from 6 Canadian serosurveillance studies. So this included a de novo cohort from StatsCan, which was the CCAS1 study, 2 convenience samples that tested leftover blood specimens, either from blood donations, which was the CBS study, or from outpatient lab testing, which was the APL study, along with 3 probabilistic surveys. So this was the Action to Beat Coronavirus study, the Canadian Longitudinal Study on Aging COVID-19 Substudy, and of course, also CanPath's COVID-19 substudy. And we compared these studies to the 2016 Canadian Census, and we used data on age, sex, race, or ethnicity, urban or rural status, along with material and social deprivation index. And the material deprivation index is a measure that reflects access to essential material resources, while social deprivation is a measure that reflects the fragility of a person's social networks. There we go. And we restricted our analysis to participants who provided their age, province or territory of residence, and a serology sample. And we did this so that we can match the age and provincial composition of the census data to the study inclusion criteria. So, for example, when we analyzed the APL data, which was only collected in Alberta, we only compared it to census data of Alberta residents. And we assessed representativeness using a representation ratio, which is shown in the formula at the bottom of the slide here. And the ratio compares the proportion of specimens from a study belonging to a subgroup, so say 18 to 25-year-old men, and it compares it to the proportion of the census population that belongs to that same subgroup. So if the ratio is less than 1, it indicates the subgroup is underrepresented compared to the census, while a ratio greater than 1 indicates overrepresentation. And we use bootstrapping to identify significantly underrepresented subgroups. And we set a threshold that if 95% of bootstrap replicates produced a representation ratio less than 0.75, we said the subgroup was significantly underrepresented. There it is. And just before we get into our results, here's a quick summary table of the included studies. So if you see this age column here, this is actually the minimum age of participants that we included in our analysis. So you'll notice that the APL and the CCAS1 studies included children, while the rest of the studies were restricted to adults. And of these, you'll notice that the minimum age of the CLSA was noticeably higher than the other studies, but this makes sense considering it's a study on aging. And so when they recruited participants, they aimed to capture middle-aged adults. And looking at region, we can see that most studies collected specimens from many of the provinces and a few from the territories as well. And if you look at the study time and size column, you'll notice that the two convenience samples, so APL and CBS, were able to collect a lot more samples from a lot more participants compared to other designs. So on to our first set of representation ratios. So you'll notice in each box we have the study at the top, and then these are representation ratios split up by sex, which is shown on the x-axis. So we set kind of three categories. So if the representation ratio was less than 0.75, we said the subgroup was underrepresented. If it was between 0.75 and 1.3, we said the subgroup was well represented. And if it was above 1.3, we said the subgroup was overrepresented. And so looking at the representation ratios across studies just by sex, we can say that they were pretty adequately represented across the studies. And next, we'll look at the representation ratios by sex and urban-rural status, which you can see on the right side y-axis here. And here we start to see some noticeable differences. So subgroups with from the urban subgroup were all adequately or overrepresented, while we see that in some of the studies, there were some rural sex subgroups that were underrepresented. And then if you look at the next set of representation ratios in the fourth and fifth column here, these are representation ratios by sex and then self-identified race or ethnicity subgroups, which we categorized into either racialized minority or white. And we see a similar kind of discrepancy here for the subgroups, including the individuals who self-identified as white. They're all either adequately or overrepresented. But if we look at the racialized minority subgroups, we see that a good number of them are underrepresented in the included studies. And of these, the studies where racialized minorities were best represented are the CCAS-1 and then also the ABC open cohort generally. And this next plot shows representation ratios when we also include age and material deprivation index. So the top part of this graph is identical to the previous slide, except you'll notice on the left side y-axis here, we've also stratified the representation ratios by age group. And this showed a couple of interesting things. So first, representativeness tended to improve as age increased across the studies generally. And also, if we compare between the two convenience samples, looking at the urban and rural subgroups here, you can see that participants that were aged 46 years or younger tended to be better represented in the CBS study, whereas if participants were aged 47 years or older, they were actually tended to be better represented in the APL study. And comparing between CLSA and CanPath, which were two pre-existing closed longitudinal cohorts, we see that older age groups do tend to be overrepresented, which makes sense because these were two studies that were started quite a while ago, so that lined up with our expectations. And in the bottom portion of the figure are the representation ratios by sex and material deprivation quintile. And you can actually see that in 3 of the 4 studies, participants living in highly materially deprived regions are actually underrepresented relative to our comparator census dataset. And these are the representation ratios by sex and social deprivation quintile. And unlike the material deprivation quintile, we don't really see any pattern here to representation. And in fact, most of the subgroups are fairly well represented across all the studies for which we had data that was available for the social deprivation quintile. And super quickly, I did want to overview another analysis we did to assess the potential for statistical adjustment and the ability to potentially correct for imperfect sampling. And so in this analysis, we calculated the proportion of cells that had a count greater than 25 when stratified by each combination of variables in the top row here. And the thought was if a study did not have a lot of cell counts greater than 25, then they may not be able to appropriately adjust. And we see again that the convenience samples, because they're able to recruit more specimens than the probabilistic designs, they had a lot more subgroups with counts greater than 25. But if you compare along the remaining studies, you notice that the two pre-existing closed cohorts, so CLSA and CanPath, produced a greater proportion of cells with counts greater than 25 compared to the other probabilistic designs, so ABC and CCAS1. So I think one of the most interesting findings was that we found several subgroups that were frequently underrepresented in the included studies, which were racialized minorities and rural subgroups. And we also observed some notable patterns in representation across study design. So between convenience samples of the residual blood studies, we saw highly materially deprived participants were underrepresented in CBS, but not in APL. And we also saw that older age groups tended to be well represented across the pre-existing probabilistic cohorts, so ABC, CanPath, and CLSA, although the younger age groups were better represented in ABC, but again, this was to be expected. And we also found that residual blood studies, so the CBS and APL, were actually more representative of some population dimensions than other study designs. And this suggests that they could be a cost-effective avenue to obtain representative data in resource-constrained settings. But probabilistic designs also have some big advantages too, like CanPath. So those with sampling frames tend to have more contextual data, including, as Alton mentioned, non-response, that can be used to characterize and improve generalizability. So it's definitely something that's worth consideration when designing these studies. And our study did have some important limitations. And so one was with the measurement of race or ethnicity. So some studies had different categories or the number of options that a participant could collect, and this limited our ability to assess representativeness by certain subgroups. And another limitation is that we only considered representativeness along 6 demographic variables. So there are many more that are likely important contributors to generate representative estimates, and in this space, particularly those related to health and disability. And our study was a small sample of all the studies that were done in Canada, and these other studies were done on important subsections of the population that we didn't include here. And also, we didn't account for the fact that each study may have different goals. So, for example, the ABC study intentionally oversampled adults older than 60. But to wrap things up, representativeness is tricky for all study designs, but I think what we showed here is that there were several subgroups that were commonly underrepresented across study designs in these serosurveillance studies. And considering representativeness is an important consideration during the design phase of these studies to help identify health inequities. And with that, I will pass it off to Yuan.
Great. Thank you, Matthew. And I'm going to give Yuan control. And also, everyone, please feel free to start putting your questions in the Q&A. I see one that we'll get to in just a minute. So you now should have remote control, but if it's easier, I can also just advance the slides for you.
Okay. Thank you. Let me try. Oh, yes, the control.
Do that.
Nice. So now I will continue on talking more about the adjusting the representativeness error when we analysis the multiple surveys involving the COVID-19 surveillance study. So the main objectives is assessing the population and seropositivity across all the studies and all the differences that, as Matthew mentioned above, with the design purpose difference and the population that recruiting difference. And we want to determine that which adjustment method that leads to the greatest concordance across all the studies. And then next. So the methodology we proposed to use in order to apply the statistical adjustment is MRP, which is a multi-level regression with post stratification. And also with the unadjusted effects from all the involved studies, which is straightforward when we compare the result across studies. And following study is the simulation study involving the exploration of the further representativeness bias in the largest data set, which is the Canadian Blood Services blood testing samples. And another final analysis is risk factor analysis involving all the involved studies, which we are trying to find what the unconsidered measurements that may lead to the discrepancies among those studies. And first, we all acknowledge that all the involved studies, they may have different specimen collections and mainly three types, the serum, plasma, and dry blood spots. And all the CBS are the serum, while the APL involves plasma and serum and some another kind of plasma. All the cells A involved part of plasma and also part of dry blood spots. And ABC, CCAS, and CanPath involved all the dry blood spots. And also we experienced the challenges with the different time period. So the partial overlap in the data collection period and the defined, we typically defined the 2 to 6 months periods with the sufficient overlap to access the methods across the province or the regions. And for the particular studies, we also compared the seropositivity over time using the multi-level logistic regression with blinds. So those are the CCAS data and the CBS data because they provide us most sufficient samples. And here is an overview of all the collection period. And the next one is with the methods for our zero prevalence estimation is basically we designed two settings. So based on the sample size of each study, there are like limited time, limited resources to do the temporal regression with blind, which is a more specific way of like tracking the seropositivity over time. Well, we do have a comparison of the all non-temporary setting, which we compare the multiple adjustment method. So either it's no adjustment or some traditional conventional method has been applied as ranking and post-stratification and ranking on the multiple more features. And finally, the MRP, which we thought is the most the method that applied most of the features of each service and can apply the most fine adjustment based on the age, sex, race, etc. Some demographic features. And also the temporal regression was blind, which we want to compare the CCAS and CBS basically to study the further trend of the adjustment as the pandemic progress. Yeah, so here are the glance of the 2021 seroprevalence by the region period by multiple studies we have, and the seroprevalence are from 1% to 8%, and the MRP method shifted the study different directions in different regions actually by up to 2%. And also the Rogan-Gladen method has been applied upon the MRP adjustment. However, it sometimes made less difference. You can see that the cross and the square cross and the circle overlap a lot of the times. So particular for the CanPath data, you'll see a lot of the overlap of the Rogin-Gladden method and upon the MRP adjusted, and which shows that sometimes the Rogin-Gladden assay performance adjustment is not changing the result so much. And also we have the result of the 2022, and you will see some huge change after applying the Rogin-Gladden upon the MRP. So which shows that it highly depends on the study to study, that whether our adjustment works or not, or it changes the result dramatically or just a little. Next, we have the Omicron seropositivity. So as just mentioned, the CBS and CCAS data provide us the enough volume to identify the adjustment more specifically. So this is a graph of comparing the different methods of the least adjustment, which is a no adjustment, to the most fine adjustment, which is MRP. So in between, are we increasing the level of the features that we consider the margin is fixed, so that you will see from the plot that sometimes we see there is a partially improved concordance between the studies of the time, but it's highly depend. And you will see that sometimes the square plot, square point here are close, but sometimes compared to the other regions, it's not necessarily the case. And here is a more specific temporal seropositive estimation. And also during the Omicron, we have the most of the data comparing the CBS, which is Canadian Blood Services, samples with a CCAS sample. And in the temporal regression, because the time period are chunked into small time period of study, so we have find that post-stratification had a little impact on seropositivity over time and on concordance between study populations. And next, so we have the MRP in the CBS subpopulation study. So the goal is to find what the MRP can adjust in a synthetic setting, which we use the same source of data just collecting from the CBS. And we subsampled using the subpopulation based on the CBS unbiased or bias very with a high potential, and the bias with low potential, which is we oversampled some particular demographic group, and test that if that works on the single resources, just getting rid of all the unmeasured errors when we're comparing across studies. And here is the result. We have that unadjusted seropositivity closer than between study estimates. And the distance between the studies with post-stratification lower by 39% to 77% in every region, which means that the MRP did work a lot in adjusting single study, but there are a lot more challenging, as we just saw that when applying MRP in cross study comparisons. And finally, because a lot of factors involving of the seropositivity estimation, And here we just want to do a factor analysis, putting all the resources of samples together, and also the serum type and assay type together with the demographic features that we consider in the MRP model, that to analysis the association between the characters and the odds of the seropositivity, to identify the potential fact that might lead to this discrepancy of the studies when they presenting their seropositivity estimation. So we can see that the odds ratio of 2 to 3 for the age, for the features of age of the 18 to 26 group, and ACG assay with the Abbott assay difference of is also plays a lot impact in driving the odds up, and the sample collection of the venous draw, it's the type is also make a difference. And as a specific type in the end seems to be a large effect in the seropositivity estimation. So yeah, that's it. Alton, back to you.
Great. Thank you, Yuan. Yeah, so that analysis I think was quite interesting because we originally went into it hoping to find that, we found the perfect method to adjust for representativeness. We ended up kind of finding that these demographic factors are less important than the other differences between studies, such as what assay they used and whether they used dry blood spot or a venous sample. So looking forward, there are, of course, other dimensions of representativeness that we can consider. So if we're able to, we can map to postal codes to look at area level indications. So those social deprivation and material deprivation scores that Matthew presented, those are area level, which can be quite useful to kind of get to look at some disparities on dimensions that we don't have individual level data. We can also ideally administer a questionnaire to ask whatever we want of participants. And we can also potentially link to administrative data to get, to get more richer covariates about individuals, particularly health covariates. The challenge, of course, is concerns around privacy and consent, having alignment of kind of priorities across the different owners of these data. As one example, so Canadian Blood Services has their study. They linked it to ICES, which provides very rich data all about demographics and health system utilization and different health outcomes. And then we have a study where we're just now analyzing data by linking the Alberta Precision Laboratory data to the Alberta Health records. And we're also linking general population comparators, which allows us to compare the representativeness of these two samples to the general population on much more dimensions than we looked at in Matthew's paper and that we adjusted for in Yuan's paper. The problem is that getting these data linked took us 1.5 years about for Canadian Blood Services and almost 3 years for Alberta Health Services. So this is, nice as kind of a post-mortem analysis, but these types of timelines are obviously completely not kind of viable if we want to use this information for real-time public health decision-making. We can also synthesize data across different modes, which I think is really promising because there's some complementariness between some of these. For instance, most of the health surveys, including CanPath, tend to have more women who participate than men. Conversely, blood donors tend to be more male than female. So you could imagine that these kind of like reciprocate each other's kind of vulnerabilities. You can imagine that kind of using different populations and bringing them together could be a really nice strategy. However, the challenge is that we found in SARS-CoV-2 is that there are other differences in the data collection that actually seemed more important than the demographic differences in who was represented. And so we would need to either have better standardization of assays and samples or we would need better methods to adjust for these differences. Now, there's also privacy concerns when we're talking about different data that's housed different places. There are these kind of federated learning or federated modeling approaches that could potentially be used. And actually, Matthew's thesis project was originally supposed to be looking at a federated methods to adjust for representativeness. But what we ended up finding is that the heterogeneity and the data generating processes was just so great that, that adjusting, these federated ways to adjust for representativeness, like they just weren't the main problem. So we ended up pivoting to what he presented today. And there was another paper that came out earlier this year out of our research group. So Jiacheng Chen, he's now a postdoc at University of Montreal, but he was the lead author on this analysis, showing like a simple regression approach to adjust for the two main anti-N assays that were used for SARS-CoV-2. Okay, so just to wrap up, and then we can go to the questions. Representativeness is a challenge for all study designs. Certain residual data streams are actually well suited for certain use cases, which is perhaps counterintuitive to kind of the conventional wisdom that a probabilistic sample data set is always better. However, you do have the limitations of not having as much contextual data. You don't have a sampling frame. So there are some limits on how you can adjust for that. So in the case of SARS-CoV-2 serological studies, population samples seem to not be the main cause of why estimates were different across studies. It's hard to kind of exactly attribute, but it does seem that differences in which assays were used, what thresholds were used, and how they were calibrated in that lab, whether it was a dry blood sample or a venous sample or something else, the timing of sampling, these all seem to also be very important. And this might be particularly true because the sampling of SARS-CoV-2, these assays had all been developed within just like a couple of years of when they were used because it was a new pathogen. So this might not be as much of a problem, perhaps, for more established pathogens with more well-characterized assays. Or if you were to do it now, we might choose different assays or have better standardization. And another important fact is that we can only account for measured variables. So improving both the capture of race and ethnic data in Canadian administrative health data would be very nice. And also just standardizing the way that we ask it across studies would be great. And having timely linkage to administrative data would be very useful to help us both assess how different populations differ and then improve and adjust for underrepresentativeness. So I want to thank all of our collaborators on these studies. Yeah, happy to take any questions. And I see there's already some in the chat.
Great, thank you so much. Yep, so we do have a few questions. The first is from Bart Harvey, and he's wondering, how do we know that respondents from an underrepresented group are actually representative of those from the group who didn't respond? Can't adjusting for them still result in a biased estimate?
Right, yeah, so we can only adjust for what is measured. Right, and there are definitely, we know of some biases that are just really hard to kind of quantify and put a label on. So for example, like blood donors tend to comply more with public health kind of recommendations generally. Cancer screening rates are higher in blood donors. And I think this is probably true as well for people, the type of people who agree to participate in a longitudinal health study like CanPath is probably on average a more health conscious individual, and maybe a person who has less kind of stress and craziness going on in their lives that enables them to participate. So it's hard to adjust for these when we don't have both an empirical measure of kind of what's the prevalence of these behaviors or traits in our study, as well as what is the distribution in the population at large that we're trying to generalize to. So I think, yeah, so we can't eliminate bias if we don't measure every single variable that is potentially, both differentially represented in our data set and potentially correlated with the outcome that we're trying to estimate.
Great, thank you. So for the convenience sampling, were participants who donated their blood, how was the consent obtained to use those samples in this serosurveillance study?
Right. So both the blood donor and the outpatient lab studies did not obtain specific consent for those studies. Blood donors do give broad consent for having their data used for kind of improvement and kind of analyzing the safety, of the blood supply. But there is this tricky, legal kind of question of when is it ethical to kind of use these samples for health research or kind of public health practice. And generally, if the primary purpose is public health practice, then you, in certain cases with ethical approvals, you can use these samples for that purpose. And because this was an active pandemic, people saw fit to kind of permit this without getting specific consent. Although I should say that Canadian Blood Services now has this, I believe it's called the Healthy Generations Project, where they're asking their blood donors to explicitly consent to having their data used for health research, including health research that's trying to benefit the general population, and they're consenting their donors, and that's something that's I think the enrollment is happening now. And in other countries, we've seen very high, like 96% of people in Denmark who donate blood or asked agree to participate in the Danish blood donor study. So blood donors tend to be the type of people who are happy to have their data used for research.
Yes. In fact, the questionnaire being implemented by Canadian Blood Services is the same one that's been used in the CanPath cohort. So we'll be able to harmonize our data and do some pooled analyses across both cohorts.
Great.
Okay, a friendly plea from Bart: could physical distancing be used instead of social distancing, sort of as a terminology? Especially during COVID, we wanted people to socially support one another while also maintaining a suitable physical distance from one another, didn't we?
Yeah, so yeah, that I think that makes sense to me. So point well taken. I'll try and do that in the future. Thanks.
Do you have a sense of which method of collection, dried blood versus serum, is more accurate? Is there any opportunity to calibrate the results from different sample types?
Yeah, so the venous blood draw is definitely more sensitive. Because the dry blood spot, right, you're doing like a capillary sample. And I do work on kind of the hemoglobin testing for blood donors, and we already know that even when you just do the fingerstick capillary hemoglobin, you have more measurement variability than if you do a venous blood draw on the same analyzer. And in the case of the dry blood spot, not only is it a fingerstick or a capillary sample, you're also kind of putting on wafer paper and then perhaps putting it in the mail. So the quality of the sample is going to be a bit degraded. So you're going to have lower sensitivity. We do have a paper that we've revised it. So hopefully it'll be out soon. Because the CLSA, the Longitudinal Study on Aging, they had participants kind of do one or the other, and we did this propensity adjusted analysis, and we did estimate kind of how much less sensitive the dried blood spot was, and we also found in the literature this really simple kind of adjustment equation to try and go from to take a crude prevalence ratio from a dried blood sample and see what we think it would be if a venous sample had been used. And we applied it to the CLSA, and it actually did pretty well in terms of making the propensity adjusted estimate from people who provided a dried blood spot look like the propensity adjusted estimate from those who provided a venous sample. So yeah, so I think there are ways to adjust for it. It's important that people are aware of how influential things like the mode of sampling or the assay choice can be, and that they do adjust for it, and also that when you're reporting kind of to the media, what's the prevalence in this population or that, you can't expect the general population to understand like, oh, this one used the Roche assay, so this one probably detected almost all infections going back at least 2 years. But this other study used the Abbott assay, so that one has waning sensitivity. So this is probably only reflective of infections in the last 6 or 8 months. You know what I mean? Like I think it's tricky. I think it would be, it's tricky when there's not standardization to know like what you can compare and what you can't, especially if we're gonna expect the general public to kind of understand that.
Right. Okay, thanks. And I'm just wondering, so given the strengths and limitations of each of these different study designs, is there one particular design that you favor over others when planning future serosurveillance studies? So I'm thinking of CanPath in particular. We had data on potential confounders like vaccination status, and their employment, so we knew who was an essential worker and who wasn't. And these are traits obviously associated with seropositivity. So we, in theory, could adjust for these confounders, come up with these subgroup specific valid estimates, weight them, so that they could mirror the population distribution. And other studies, while they might be more representative in terms of, racialized minorities or age groups or sex, they're sort of limited. Even if you did administrative linkages, you might not capture all of those essential variables. So, do you think that those variables are essential? And do you favor any one particular design?
Yeah, so I definitely think, the richer data that you have, the better, of course. I think, yeah, I think, but I personally, I don't know how realistic it is in the short term, especially given that investment in kind of serosurveillance is definitely down from what it was in 2020 and 2021. But I think that it would be good to have multiple potential sources with strong contextual data that we can get by linking to administrative data sets. And then, of course, whenever we can ask people questions, like to the blood donor. I think the value of the blood donor for general population serosurveillance is certainly enhanced now that we're trying to enroll the majority of the CBS donors in this generations project and ask them these questions. But I think, anyway, I do think that longitudinal cohorts have, like CanPath, definitely have an important value at looking at kind of how things evolve over time. Maybe not so much over like the very short timeline of like immune kinetics just after vaccination, because you're not sampling multiple times a year. Like that type of research might be better in like a cohort of plasma donors or platelet donors who are coming back several times a year. But looking kind of more long term at these types of things, there's definitely tremendous value in studies like CanPath because of the repeated sampling and the opportunity to kind of recall people for additional sampling and the really rich covariates. So.
Okay, great, thanks. Sort of a comment here, following up on the CBS cohort. It would be interesting to know whether the representativeness will change once the new consent procedures are integrated into the convenience sampling. I assume it will take time to go through the new consent process.
Yeah, so I think that we can still do serosurveillance in blood donors who haven't consented and haven't done the questionnaire. We'll just have richer data once they do it. But as I said, in Denmark, it was, the rate of people who declined to participate in that study was 4% of blood donors. So it should be quite representative of the donor population. But we know the donor population is not representative of the general population. It skews male, and then quite importantly, for certain pathogens, you cannot be someone who's gotten a tattoo in the last 3 months, had a new sexual partner in the last 3 months. Certain rural areas, it's just not cost efficient to do collection there, so they will be very underrepresented. So I think if it's like Denmark, where over 90% of the donors agree to the healthy donor, enroll in this study and agree to have their data used like this, then I don't think it would. I think that it should still represent the donor population quite well.
Right. No, I agree with that. And you sort of alluded to this, the fact that there's not really as much, funding, obviously, for serosurveillance as there was during the peak of COVID. And obviously, we're no longer measuring SARS-CoV-2 seroprevalence. But what exactly is happening with serosurveillance in Canada?
Yeah, so I know at least the work that the COVID immunity task force towards the end in 2023, 2024, we kind of tried to develop a plan of this. We called it HEMA-Net, so kind of blood-based surveillance network of different organizations that do routine testing, like the blood collectors and the outpatient labs, and longitudinal cohort studies like CanPath. And unfortunately, it hasn't gotten sustained funding, which is a bit of a shame because, a lot of people rapidly developed a lot of skills when it came to both the laboratory side, the analytics side, the infrastructure side of all of this to facilitate this kind of massive investment, unprecedented investment in serosurveillance. But unfortunately, without funding, people are going to find jobs in other sectors, and we're probably going to lose some of that expertise. But there are, of course, still initiatives. So the Popcorn Initiative is one using residual blood in children. And I believe that a group did get some funding from CHR recently, but it wasn't our group, so I don't know a whole lot about it, what they're doing. But I don't think it was specifically the residual blood surveillance. I think it was more syndromic surveillance. So surveillance for kind of, are we seeing like an uptick in patients with certain health conditions, rather than kind of blood-based serosurveillance, which, in blood-based serosurveillance is really important for looking under the iceberg for health conditions that don't always have severe symptoms. So obviously that's SARS-CoV-2 is one of those, but there's also kind of West Nile virus, and these different mosquito-transmitted viruses that are going to be more prevalent in Canada as the climate warms. Serosurveillance, I think, is important for those.
Great, thank you so much. So it looks like we're at the end of our questions. Thanks so much for all of the speakers today, and for everyone else for joining us. If you're looking for more opportunities, mark your calendars. We have virtual access office hours, CanPath does, coming up on September 17th at 12 p.m. And you can learn more about how you can leverage CanPath data for your own research. The link to sign up for the event is in the chat. Thanks again for being here, and we'll see you all next time.
Thank you.
Thank you.
Thank you.